Hi, my name is Morgan Pike. I'm from the University of Michigan Medical School. The title of my presentation is What's That Rash? A clinical vignette about Mycoplasma-induced rash and mucositis. So our clinical vignette begins with a 9-year-old male who's presenting with 5 days of oral and penile ulcers. His history is unremarkable and his immunizations are up to date. So he initially developed ulcers on his mouth, had some swelling, redness, pain in his lips that eventually progressed to erosions. And then a couple days later, he had lesions on his penis. So his parents took him to his PCP, where they thought this was most consistent with HSV gingivostomatitis. So they just did supportive care. After about 4 or 5 days, he continued to worsen, got to the point where he couldn't eat or drink, so they brought him into the hospital. Upon further inquiry, we found out that he also had a history about a week ago of a URI, kind of cough, congestion, and other symptoms. However, at this point, it was still presumed to be most consistent with HSV gingivostomatitis, so we put him on acyclovir. After about a day, he still wasn't improving, the erosions were progressing. We had gotten some labs and an RPAN, all of which was negative. So the RPAN was actually negative for Mycoplasma as well. So we consulted with some specialists. So we brought in dermatology and infectious disease. They brought on MERM to the differential list and did some send-out antibody testing for Mycoplasma, including IgM and IgG, which ended up coming back positive, leading to the diagnosis of MERM. The images below represent the mucosal involvement. Our patients were much, much worse, but you can kind of just get an idea of what it looks like. So some background about this is MERM is characterized by prominent mucositis, usually has sparse or even absent cutaneous involvement. Most common in kids, mean age of 12. By adulthood, about 80% of adults have seroconverted for IgG. 66% of cases are in males, so a little bit more common in males than females. MERM is oftentimes kind of characterized as the spectrum of SJS or TEN or EM, but it actually has distinct morphology, a bit more of a mild disease course, and some potentially important clinical implications that led to its own kind of diagnostic criteria, and this disease being coined back in 2015, so relatively new. The diagnostic criteria entail having evidence of an atypical pneumonia by clinical symptoms, so fever, cough, physical exam findings, or such, and then a mucosal rash that involves less than 10% of total body surface area. So if you draw your attention down to the bottom right hand of the screen, the flow chart, this just depicts kind of the two main mechanisms of the pathophysiology. So both the direct pathway, which is local bacteria and kind of local inflammatory response via cytokines and tissue damage, or the indirect pathway, which is a distant infection inflammatory response that causes the rash through molecular mimicry and then B-cell and antibody production that lead to immune complex deposition and complement activation. So you diagnose them with MERM. How do you treat it? Right now, there's really no evidence-based or established treatment. Kind of varies institution by institution, but mostly it's just supportive care. So pain management with analgesia, and then there's also I learned about this magic mouthwash, which the kind of recipe for it varies depending on where you are, but here it consisted of an antihistamine, an anesthetic, an antacid, an antifungal, a steroid, and an antibiotic. Other adjunct therapy include antibiotics, so macrolides and fluoroquinolones, steroids and cyclosporine. All of these are done kind of on a case-by-case basis. There's really not a lot of data to support right now. There's no difference in mortality, but just in morbidity and kind of complications. So some takeaways. If you're working up someone who's got mucosal skin lesions, of course think of SJS and TEN, but keep MERM on the back of your differential, especially if it's a pediatric patient. If the RPAN is negative, but your clinical suspicion is high, then pursue further workup with serology. So I thought one interesting thing about this case was that our initial RPAN was negative, but then the send-out antibodies were positive. So we know IgM is acute and IgG is chronic. They usually peak from the 4th to 6th week, but just kind of remembering the timeline and the utility of testing is always important. So that's all of my presentation. Thank you very much for your time and have a nice day.